So we'll let people in, and then we'll give them a minute. Welcome, 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 everybody. Great to see you here. We'll just wait a minute for people to get here, and then we'll get going. Thanks, everybody, for coming. And we'll get going in just a few more seconds as people are starting to come into the Zoom room. Welcome, everybody. Welcome, welcome, welcome. Thanks for coming, everybody. All right, well, it's 2 minutes after afternoon, and there'll be a few more people coming into the Zoom room here, but thank you all for attending. My name is Dr. John Kelly, and I'm the director and founder of the Recovery Research Institute at the Massachusetts General Hospital. Delighted to be here. We have an extra special guest with us today for our webinar, who I'll introduce in a second. Let me just go over a few details about our goals and mission for the science recovery science webinar series. As many of you know who are returning, but for those of you who do not know, who are new, this is part of a SAMHSA-funded Opioid Response Network initiative, where we're trying to disseminate information about how to address the opioid crisis, as well as the stimulant crisis, as well as disseminate information and train people and provide training and expertise consultation regarding improvements in care for individuals with opioid and stimulant use disorders, as well as other substance use disorders. In this regard, I'll just play a brief video that will put you in the picture, I hope, better than I can explain it. Here it is. Let me just share my sound.
We are the Opioid Response Network, a coalition of 40 national organizations representing more than 2 million people. We serve all 50 states and 9 territories locally through our network of nearly 1,000 professionals working across prevention, treatment, and recovery. For state agencies, organizations big and small, and individuals working to address local needs, we bring training and education to bear on your efforts. We're here to help you help others through evidence-based support, all at no cost to you. For instance, the Opioid Response Network helped the Tribal College in New Mexico join forces with local organizations to develop a culturally appropriate prevention, treatment, and recovery training series for its students. In Rhode Island, we convened correction staff from 34 states to share how our program had reduced post-incarceration overdose deaths by more than 60% and supported them in their efforts to build similar programs in their home states. In West Virginia, we mobilized to help a clinic incorporate substance use disorder services into their practice, serving a faith-based community. We helped healthcare providers in South Dakota address barriers they face providing treatment services for their patients. We're here to help those on the front lines. So, what are your needs and how can we help? Visit the opioidresponsenetwork.org to learn more and to submit a request for support. The Opioid Response Network, funded by the Substance Abuse and Mental Health Services Administration.
There you have it. That hopefully puts you in the picture. What's nice about this is that there is a freebie. So if you have needs in your program, or you yourself want more education, training around how to deliver services for patients with opioid use disorder or stimulant use disorder, you can reach out to the Opioid Response Network.org, get a free consultation, get help, get people to come and train your staff on different aspects of best practice. So it's a really nice federally funded thing that we have to be able to deliver. Please let people know about it because obviously it's a freebie and we can improve care for patients with these disorders through this mechanism. So thanks for your attention. Let me just share my slides again. And get rid of that one. And hopefully you can you see those? Yeah, great. Yeah, so again, this is, I think, number 9 or 10 in the Recovery Science series. As you can see, we've had a number of prior webinars in the Recovery Science series listed here. These are all available, archived for viewing at any time. So please avail yourself, let people know about these resources. And I'm really delighted and honored to be able to introduce our speaker for today, Dr. Keith Humphreys, Professor Keith Humphreys, who is an endowed professor at Stanford University in addiction. I've had the great privilege and pleasure of knowing Keith and actually working with Keith many years ago as a kind of a mentee of Keith's for many years. And Keith has been a mentor throughout my career. He's helped so many people like me, inspire many people like me in the area of addiction health services, including in this area of mutual aid and mutual help. He's also an honorary professor at King's College in London. Keith has done a ton of things. He's been a senior policy advisor to the Obama administration at the Office of National Drug Control Policy. He's published hundreds and hundreds of papers, high impact papers, including a comprehensive review of best practice and in the opioid crisis, published in The Lancet just this year, I think, Keith, wasn't that, in 2022? Yeah. Among many other very high profile, important, high impact contributions to our field. So thank you, Keith, for all that you've done to help so many people. I mean, you've really inspired a generation of researchers and had a major impact on the clinical science and health services front that will go on, your legacy will go on for many decades to come. So thank you for everything that you've done. You've poured your heart and soul into this, and thank you for coming and doing this today. So I'll hand it over to you, Keith, to share your slides.
Okay, can you see my slides? Yes, okay, great. Yep. Thank you, John. That was a very gracious introduction. And obviously, I feel very blessed that I got to work with John when he was in Palo Alto. And we've, as you'll see in this talk, we've gotten to continue to do work together, which has been a great joy to me. I'm going to talk about mutual help groups as a addiction recovery source. And I'm going to start to tell you candidly, I really used to have a very negative view of these groups. So I started my career in the addiction field a long time ago now, over 30 years ago. I got into it because I needed a job. It was not exaggerating. I was flipping burgers. I was making minimum wage, which was $3.35 an hour. And there was a job opening at the medical school where I was a college student that paid $4.40 an hour. And I applied for it because I wanted the money. I knew nothing about addiction. Wasn't particularly interested in addiction, but that's what it was. And on that project, I met people. There were several people who were in AA and NA, and I didn't know what they were. And when they told me about it, my first reaction was, I didn't say it out loud, but was, boy, that sounds really stupid. I don't see how that could work. You don't have any doctors there. You don't have any medications there. How could you possibly resolve such a serious condition by sitting around and talking about your experience, strength, and hope? And now in the interim, decades, I've recognized how wrong a reaction that was on my part, because the evidence had just, as I'll show you, shows that was a sort of a snobby and incorrect take on things. But I do understand why people have that reaction. I mean, we aren't, it's outside of our professional training. And we don't run it. I think there's natural skepticism. So if you're skeptical, I understand it, because I started my career very skeptical of these groups too, and now have come to see them as an evidence-based resource for the reasons that I will show you. Okay, so so there's really no chance of a conflict of interest here. I'm just going to be talking about a free a mutual help organization in which I have no stock. Okay, so one interesting thing is there's a whole range of these groups all over the world, and they're really different. The Blue Cross was founded out of, I think it was the Catholic Church in Europe. Via Libre, which is a French group, came out of the workers' movement, like labor movement. SARDA is an alumni group, which came out of the treatment system in Hong Kong. Danshukai was influenced by AA, but is also distinctly Japanese in many ways. Abstainers clubs in Poland are not anonymous, and they have a TV show and a magazine in your Republic when you're an abstainers club. The Lynx is a Swedish version, but AA influenced, but again, it's own thing. And then I just put this one because it surprised a lot of people. Narcotics Anonymous in Iran, something like a fifth or a fourth of all the world's members of NA are in Iran, which, for years it was said this because was originally sort of, I guess you'd say, sort of Protestant coded in its early days. People said this will never spread to a Muslim country, but it has. And there's many others. And I think this just tells us something about the nature of addiction. There's something in the condition, no matter what country you're in, what background, that you want to come together with other people who share the problem and try to work together to recover and make your life better. And that basic human need, I think, is entirely understandable particularly for a stigmatized condition like addiction. I'm going to talk the most about 12-step groups today, particularly AA, not because they're the only ones, as I said, but because we have the most evidence about them. They've been studied the most. So you probably all know this, but let's review the facts. It was created in Akron, Ohio, about, what is that, almost 80 years ago. And the sole purpose was to help alcoholics become sober. I put alcoholics in quotes because it's not a word I would ever use myself, like in clinical care, but the members call themselves that. So that's what they say. And the sober doesn't just mean not drink. It means to have a better, richer life, a life characterized by kindness and altruism and honesty and spiritual growth. There are meetings, of course, everyone knows that. There's also sponsorship, where a senior member helps a junior member find their way. There's lots of books. They have the 12 steps as well as sort of a pathway to change. You don't have to work them. They're described as but suggestions, but many people do. There's another word in quotes, disease model. They do call it a disease, but they don't. The reason I put it in quotes is they don't really mean it the way we would say at the hospital cancer is a disease. They thought of it as more a sort of spiritual, psychological unease in the world, more than they didn't necessarily mean it was just a physical illness. It's grown explosively. I mean, if you just look at it in terms of just as an organization, it's shockingly successful. It had 2 people in it in 1935, and now it probably has about 5 million, and it's in 190 countries. And it's also sort of interesting. It's obviously influenced professional care, and it is the most widely sought source of help for alcohol in the United States. If someone is leaving their house right now in this country to go seek help for an alcohol problem, the best bet is not that they're coming to see someone like me or like John or any of you, but actually that they're going to a meeting. It's the largest resource.
Yeah, and I applied to them.
And looks like we need some mute from somebody, please. But the fact that it's super popular and well spread doesn't mean that it works. There are lots of things that are popular that don't work at all. CBD cures everything. All these people are taking CBD. That doesn't prove that it cures everything. I used to give an example. My grandmother took something called Carter's Little Liver Pills, which many older people used to take until the FDA ruled they were inert. They have no effect on the liver at all. And so they just changed the name to Carter's Little Pills, and people still took them. So the fact that people take things or participate in things does not prove that they work. And that's where science comes in. You have to test whether or not things work. So this, to me, is a real pivotal study. It was, I'm proud to say, done by my friend and colleague, Chris Timko. And this is a VA study. It was done in our hospital. And it was we had a lot of, weak studies where, people would show up at a meeting of AA or NA and say, look, the people who have been going the longest are doing the best. But there's lots of reasons that could be happening. That could be differential dropout. Those people could be just highly motivated and so on. So what's changed in the last 15 years is studies like this, where you have randomization and you have a much better basis to make judgments that are something other than self-selection bias. So what Chris did, she had about 345 outpatients who are in care already for substance use disorder, could be alcohol, could be an illicit drug. And she randomized them to two conditions. Condition one is the standard, here's a brochure, there's these 12-step groups, maybe you'd like to go. And then condition two is a much warmer handoff, where you actually spend like half an hour with the person. Here's what groups are like. Do you have any anxiety about what meetings are? Let me describe the different types of meetings. Let's find you a meeting in your neighborhood that works with your schedule. And also, I'd like to link you with somebody who's an experienced member who can take you to that first meeting. So it's it's not the whole thing. I think what she does lasts like 30 minutes or 45 minutes or something. It's not huge, but it is to sort of help people over the threshold. And in this randomized study, there was about a 60% greater improvement in drug and alcohol outcomes as measured by the Addiction Severity Index at follow-up at 6 months. That's a big effect for a small intervention. But it's not, you can't just say, well, it's the motivated people who went. It's like, no, actually, because the reason they went was that they had this warm handoff, drove up their 12-step involvement, which then they had much better outcomes. And there's been other studies like that. They're not restricted to the VA. They're not restricted to any particular scientist for that matter. Here's a nice one by Mark Litt, and this was studying network support therapy, which you may know is about helping people connect with networks where people don't drink. And of course, that could be lots of networks. That could be, a sports club, or it could be their whatever the community of faith is, if they have one, but also one is AA. And in a randomized study comparing that to a case management model for people with drink problems, they found that randomized assigned social network approach produced higher levels of AA involvement and then more abstaining days. And again, in a randomized trial, not in an observational study. So that's also very encouraging. I worked with an economist named Todd Wagner and a terrific data analyst named Janet Blodgett to do a integration of all these studies using something called instrumental variables analysis. And I'm not going to explain what it is. It's kind of complicated, but it's a way to get an estimate in a clinical trial of the impact of something free of self-selection bias. So we took all the studies that the federal government had funded in VA or at NIAAA, and there were 6 of them with over 2,300 patients. And we used the instrument to say, could we see an effect of AA per se, not just the intervention that made them get into AA, not just the facilitation, but the actual AA itself. And it did show up to have a positive effect in 5 of the 6 trials. So again, pretty encouraging. We've extended this to drugs. It turns out there are also a number of NIDA-funded trials that look at illicit drug outcomes. And John Kelly was one of the contributors to this, along with other great scientists around the country. And we tried the instrumental variable analysis again. And I have to say that the results were not as strong as they were in the AA study, because for instrumental variables to get rid of the self-selection bias, the facilitation intervention has to have a big effect on attendance, and it really had only a small effect. So that's an interesting thing about this, is it's harder for clinicians to get people to participate in AA and Methamphetamine Anonymous and Cocaine Anonymous. I'm sorry, I said that wrong. It's harder for them to participate in groups that focus on illicit drugs than for alcohol. That's a simpler way to say it. We did, though, run more traditional regressions. We found 2 things that were encouraging. One is that there is no diversity bias. In other words, men were as likely to go as women, and people of all different races were equally likely to go. So that's certainly good. We want to see that. And we ran these are traditional regression models, controlling for as many things as we can, and do show improvements in drug problems. At the same time, remember, these are not that we don't have the full protection of instrumental variables in a trial. So I would say overall, this could be biased. So, the evidence for AA is stronger than it is for the drug groups. I would add also, if you're going to compare things to other treatments, of course, in stimulant disorder, and most of these patients had stimulant disorder. Of course, we have a lot of things that don't work that well, but I would say that evidence here is not as strong as we've got, say, for contingency management, which works pretty well, consistently well in trials. And for the opioids, I wouldn't say that evidence here is as strong as we have for FDA-approved medications. So if I was going to rank a hierarchy, that's how I would do it. Now, of course, people can take medications, go to groups. There are some tensions there. I'm going to talk about them later. I got interested in just the question of, given that these groups are free, what is the cost implication of them? Do they in fact save money? And we're always asked in the public sector to, consistently, take care of more people with less and less money. And we certainly experience that in the VA where I work. So I did the study with my mentor, Rudy Moose, of trying to figure out if there was a cost offset to these groups. And this was a large study. It's 1,700 VA patients around the country, racially diverse, but not gender weakness here. These are all men. And we contrasted 10 good programs. These are 21 to 28-day VA programs. They were all high quality, but they were different in how their approach was. 5 were very 12-steppy in every sense and really, trying to get people into the program. And the other 5 were cognitive behavioral programs that really didn't emphasize that. Nothing wrong with cognitive behavioral treatment. I've trained in it. It works. But it's just pointing out that this is a different kind of, they were different. They weren't better and worse. In the design, this is not randomized, but the nearest 2 programs are hundreds of miles apart. So, you would expect mostly people are not going to drive 1,000 miles for a 12-step counseling session or a cognitive behavioral session, that people show up at the nearest VA and they get what's available. So it's not randomization, but it's also sort of quasi-experimental, you could say. We matched people using VA databases on their prior mental health and substance use care utilization. Then we compared them on every possible prognostic thing we could think of. They weren't different. And we followed them up to see what happened to the 2 groups. So first off, as you might expect, if you went to a pretty 12-steppy oriented program, you were a lot more likely afterwards, a year later, to have a sponsor, be going to groups and going to more groups. Some people do go after cognitive behavioral programs for sure, but at a lower level. And then the outcomes were pretty similar with one exception. And the exception was abstinence. So this was a pretty tough measure. It was 1 year of perfect no use of anything at all. Thankfully, a lot of people are there, but it was significantly higher if you went to the 12-step condition, which is the orange bar in this chart. We had a measure of substance use-related consequences. We had a measure of mental health. Those were the same. So mostly these treatments seem to be equally good, except on abstinence, where the 12-step treatment was a bit better. But remember, the study is really about cost. That's the focus. And here's what it was. So we added up all the mental health and substance use care people had gotten in the year after treatment. And again, orange bar, 12-step condition. And you can see there was a lot more service utilization for people who had been in the cognitive behavioral condition. They have more inpatient days and more outpatient visits in the year after they were discharged from these 21 to 28-day programs. So put these 2 things together: less spending, but as good or better health. That's unusual. Usually in healthcare, we spend less, we get less health. So how do you explain this? Why aren't people doing worse when they're getting less care in the 12-step condition? We don't know, but my theory is that, if you go into any clinic, and if you're a clinician, you know this, people come in when they really need to see a doctor or a nurse or social worker, psychologist. People also come into healthcare systems because they're lonely, they're bored, they need to know someone cares about them, they need a pat on the back, they just want to talk to somebody. Those are all absolutely legitimate human needs, but you don't need a MD or a PhD or an MSW to fulfill them. So it could be what's happening is that people are now going to their groups instead of to their healthcare system to get those needs met. And you can get those needs met there because there's nothing, those are human connection things. They're not unique. Nothing in my training made me better at that than the next person. So this could be, very good efficiency in that the people who are going back to the healthcare system are the ones who really need to go back, and the rest are going to their groups. We extended that study out to 2 years. Lots of study effects fade over time, as you all know. And so, like you say, never replicate anything until you have tenure, because maybe your famous finding will go away. But in this case, it actually got stronger. 2 years later, the abstinence difference was even larger between the 12-step group and the people who've been in the cognitive behavioral care. And there was a further $3,600 healthcare cost reduction. So for the 2 years, it saved about $10,000 a patient. That was in 2014. So you can, inflate that up to now, whatever that would be, 14,000 about. But the point is, it's a lot of money. I mean, VA treats over 100,000 patients a year. You multiply that by, $15,000, $10,000, you realize that's a lot of extra budget that you could take care of more people. And so that's good. Now I'm going to move to the most comprehensive review of specifically of AA and of the 12-step facilitation interventions designed to help people with alcohol problems. And this study it's great to talk about this on the RRI webinar because it is an RRI project. I worked on it with Marika Ferry, who's at the European Monitoring Center for Drugs and Addiction, and John Kelly, but John did the heavy lifting on this by far, John and his team at RRI, so they deserve the credit for this very, very detailed review. Cochrane reviews, if you've never done one, is extraordinary how you have to publish, how you have to send in a protocol of how you're going to review the literature. That gets reviewed and critiqued. It gets put up publicly for public critique. We must have had at least 8 different editors go over every single detail of the actual report. So this is as rigorous as it gets. The design was to focus as much as possible on very high quality studies, randomized trials or quasi-randomized trials for people with alcohol problems, either AA or 12-step facilitation or both, and compare them only to really good treatments. Motivational enhancement therapy, cognitive behavioral therapy, those are good treatments, not pushover comparison conditions. We also looked at healthcare cost offsets, and we were looking at the non-coerced population and only adults, not adolescents. There's not enough data to do that. And I'm not going to bore you with this, but just to say it's a very intense literature surf process. This is all public. You can read it all online. It's just really terrific work, again, by John and his team at RRI. We found 27 primary studies containing over 10,000 people, mostly clinical trials or quasi-clinical trials. They're done all over the country. They're done by different researchers. They're also done, some are done outside the country. So it's hard to point to a geographical bias, a researcher bias, or whatever. There's a lot of data coming from lots of sources. We measured as many things as we could, abstinence, obviously, because that's the goal of these groups, but we also measured more harm reduction-y kind of outcomes, like, well, you're still drinking, but do you drink fewer drinks per drinking day? We measured consequences, addiction severity, and we also looked at economics again, this healthcare cost question. And this is probably the most striking finding in the study. This is taking a very, again, a tough measure, complete abstinence, not even a single day of drinking, and comparing the effects of the 12-step condition to cognitive behavioral and motivational enhancement. The blue bars are the 12-step ones. And you can see in a lot of these trials, the effect is very large. This is a very serious health problem. If you could increase your chance of getting better 50% or 100% for, say, cancer, you would obviously want to try that. This is just very impressive findings. I mean, that people are doing so well. But we didn't just look at abstinence. We also looked at other outcomes, as I mentioned, and on those, they were much more similar. So it kind of paralleled the big VA study I mentioned, in that on most other outcomes like drinks per drinking day and consequences, it looked about the same, but in abstinence, it looked way better. We also looked at cost again, and again found every cost study shows significant cost offsets to these groups. So they are taking a pretty big burden off the healthcare system, no doubt. So with those of us who are, work in healthcare systems should be grateful to have them because they do. It's not their purpose to save money and give us more resources, take care of people, but they do have that effect. Why does this happen? What mediates this? So mediation means, you see, it's what goes on in the black box. People aren't transformed. They go into one AA meeting, they come out 20 years sober. A lot of stuff happens along the way. What are those things causally? So we spent some trying to figure that out. This is a stripped down structural equation model. I used to put in all the betas and gammas and everything, and everybody just, their eyes rolled back in their head, or they started updating their Facebook page or whatever. So I've taken all that out. But if you want to look at all the math, the reference is down there at the bottom, and you can see it on your own time. But this is a study looking over a 2-year period with a couple thousand people. And we charted how involved they were in these groups, and then in the end of the study, they reduced substance use, but what changed along the way at the interim interviews. One of them was active coping. Active coping is how you deal with stress, not necessarily addiction related
Like
stress.
backpack?
No, I'll just.
Oh.
I think we need a mute.
Oh, okay. So
Thank you. So that's like how you deal with stress. And so, things like, active coping would be like, well, when I had a problem at work, I made a plan of action, I sought advice, I thought about different options, versus kinds of coping like I pretended the problem wasn't there, I hoped it would go away, I pounded my fist on the table to let out my upset, those kinds of things. So we saw people doing more active coping with everything, not just substance use. Motivation to change went up. People were more interested in recovery. Something that gets said about 12-step groups that is just not sensible is, oh, those are just highly motivated people who go for a long time. But you don't have a huge wad of motivation, in your heart when you start in a complicated behavior change. Oftentimes people go, they actually don't even want to be there that much. They're thinking, I'm going to go to one meeting and then my stupid spouse and my annoying boss and my crummy kids will stop nagging me all the time. But then they go and maybe they strike up a conversation, or they hear a story that catches their imagination. They think, oh, I'll go to another one, maybe and they get hooked. They get hooked on it. And then they want to become more a part of it, and their motivation goes up. So when you see a highly motivated person who's been in recovery for 10 years, it's not that they had 10 years worth of motivation in their heart their first day, but the experience of being involved was motivating. There also were changes in social networks, general friendship quality, not specific to addiction in any way, but just asking people, do you have people you trust and you rely on? They were more likely to say yes. And then they also were more likely to say, I have friends who specifically support me in my efforts to recover. So all those things change on the way to people reducing their substance use. We are far from the only group who has studied this. Many other groups have. And the findings in some ways are similar. Sometimes they identify different things. There's increased self-efficacy comes out in a number of studies, meaning not just I want to do this, but I can do it. I mentioned the strength through commitment to absence, that's higher motivation. Other people have found active coping, improvements in social support. People who engage in more altruistic behavior or say they experience a spiritual awakening are more likely to recover in these programs. And then the last is the swapping of friendships. So when people swap out friends who use substances with friends who don't. And this is a challenge, if you do clinical work, you want someone to get better, but their social environment kind of defeats them. And one place where people can find those is often in the program. And this is a study of that very phenomenon done with Jennifer Noak. And we looked at people a year after they had been in a residential treatment program, and they really broke into two groups. There were about half and half. We asked them, enumerate all your friends and how many are in 12-step. And about half of them said 90% of my friends are in 12-step. And the other half said, the red bar said none or almost none. And those also correlated with abstaining. If you had more friends who were in 12-step, you were more likely to be abstinent. Now, this is so high, it's over 90%. We can bring up something that can be annoying to family about 12-step groups, is in that early recovery period, a person can be so intensely involved. I remember someone saying vividly, well, he used to always be at the bar, and now he's always at the AA meeting. What difference is it? We never see him. So this can be sometimes frustrating about how wired in people can get. But what tends to happen over time is that people, after this intense phase in early recovery, tend to moderate their involvement and spend more and sort of reconnect with family, reconnect with work, and that kind of thing. I kind of think it like it's a chrysalis, and the caterpillar is in there. It has that intense experience, and it's going to come out and be a butterfly, but you have to wait for it. So who cares anyway? What does this mean? Well, it means we can help a lot of people fairly easily. Here's a study by Leanne Kaskudis. It's an on-off design in what is called a social model residential program. And she had a psychoeducational course called MAZE, Making Alcoholics Anonymous Easier. And it just walked people through what the program was and, any concerns they had about it and how to handle problems, how to find a good meeting, and so on. And when this course was running at 12-month follow-up, it roughly doubled the abstinence rates for alcohol and for other drugs just from the psychoeducational course. So there are ways to dramatically improve our outcomes without a lot of effort or cost. Here's a similar demonstration of that. This is an extraordinary study that if I'd heard about it in advance, I would have said was very badly designed. because it's a randomized trial of a behavioral intervention with only 20 people in it. So normally you would say you're never going to find an effect in 20 people. But anyway, this is Sisson and Mallam. So what they did was they had 20 people who were in care for alcohol problems, and they randomized them to one of two conditions. One was the brochure. There's these groups out there, you may want to go. And the other one was a more intensive referral. You would say, there's these groups, there's a brochure, and with your permission, I would like to call right now an experienced member to help you get to your first meeting. And you can see the results there: 100% success in the intensive referral condition, 0 in the standard referral. So despite having 20 subjects, they get a very highly significant finding. You couldn't be more different than 100 versus 0. It's also important because oftentimes when you ask people, do you connect patients to fellowships, they'll say, oh, yes, we do that. We give out a brochure. So just point out, if that's your standard of care, it doesn't really work. People need a little more help over the threshold. Which is understandable. It's anxiety-producing experience, right? So you want your standard care to be higher than just tell them about the group and give them a brochure. It's also important to note that this is not these findings are not unique to psychiatry, psychology, social work, and so on, but it can contribute to other parts of healthcare. So this is a study by Rick Blondell, the ER doc in Kentucky. And he's looking at people who came into the hospital through the ER with an alcohol-related injury. They are not there in their minds for alcohol problems. They're there because they had a car accident, they were drunk or whatever, and they broke their femur or something. And so he compared 3 conditions. First condition is sort of standard of care in America when someone comes in like that in terms of their alcohol problem, which is nothing. Generally, it's ignored. And the second condition was a brief intervention done by a physician, and you know what those are. And then the third condition was that brief intervention added to it a person in recovery, a peer from a local organization who would come in and tell their story of recovery. And you can see the absence rates there. The control condition did have, over a third of people absent at 6 months, probably because they had the life scared out of them by their accident. Adding that physician brief intervention raises it further, 51%. That's good. But adding the peer then adds it more. You get up to 2/3 of people being abstinent. If you look at treatment and AA initiation, the effects are even larger. Some people go just because of the accident, injury. They go a little more if they get the brief intervention. But when you add that peer, the level of health saving really jumps up to almost half the sample. Now, I want to make clear, some people misunderstand the literature and misunderstand me sometimes when I say that we have evidence, this is evidence-based intervention, that this means therefore everyone should go to AA, or we should make people feel bad who don't go to AA. That's just not right. Just like, methadone is an evidence-based intervention, buprenorphine is an evidence-based intervention, cognitive behavioral therapy is. That does none of, and no, when we see that those are evidence, we mean they are better than placebo, not that every single person should go to them. There are people who just don't like groups. There are people who feel socially anxious in them. There are people the program grates on them in some way. So you want to have alternatives, and thankfully we do have more and more. That's good because the people with the concerns are diverse, and we need diverse solutions for them. The non-12-step groups are newer historically, and they're smaller, but they are out there. And at least, where I am, there's quite a few to pick from. Most of the work has been descriptive so far. Leanne Kaskudis did a dissertation and a lot of nice papers on women for sobriety, which is a feminist alternative to AA, founded by someone who thought that AA's program was sexist. I've done some work with something called moderation management, which is for people who are not seeking abstinence, but in general, the people there, I think, are people who could be successful as moderate drinkers. They tended to be fairly socially intact with a lot of recovery capital already. So those are some, but there are plenty of others, and we need more data on them. This is a really nice study by Sarah Zemore, is the first author. Senior author is Leanne. But looking at women for sobriety, LifeRing, which we have here in California, I'm not sure how well it's spread around the country, Smart Recovery, which is a cognitively oriented program, and 12-step groups, and showing, this is not a randomized trial, but showing that it does seem across these groups that people do seem to do better, when they are involved in them, and that shouldn't be surprising. I mean, it's hard to think of a health problem that requires a lot of behavior change, where being around other supportive people who are trying to make the same change doesn't help. I mean, that's true of exercising, that's true of losing weight, true of lots of things. So be open-minded that different people will want to attend different kinds of groups. We're at an exciting moment with Smart Recovery, and then I can highlight the great work John is doing now in having a really rigorous study funded by NIAAA, and this is going to be, I think, extremely interesting to see what the effects are in this rigorous evaluation. A lot of us will be watching this closely. I want to add too that we can do stuff to help groups catch on. So I spent a lot of time in the UK. It seemed to me and some other people that Smart Recovery kind of fits a certain, might fit culturally well in the UK. So we decided to try to help spread it without taking it over, because we don't want to turn it in just, like a subset of our own treatment empire, but to kind of nurture it along. So we had a partnership between the Department of Health and Social Care, a charity called Alcohol Concern, and Smart Recovery UK. And where we had training and local champions who went to programs and would tell people about what SMART was, encourage them to refer their patients. And they also started facilitating groups at 6 different sites. And in the end, 18 groups were established in 4 regions. This is all in England and Wales. And part of what was nice was that we didn't found 6 of them. Some of the ones we founded collapsed, but then people in them would set up their own, which is the point, right? Because we didn't want to run it ourselves. We wanted to build up a mutual help network. And so that was, I think, a good effort to get more people to know about groups and participate in them. And it raised also the profile of SMART with professionals and the public. More people heard about it. And then so there was some nice coverage about it in the media, so that maybe other people found their way to it without our help, which is ideal. So what do we say as our conclusions? 12-step group participation significantly reduces substance use and healthcare costs. And that's a causal statement. I'm not talking about just cross-sectional correlations. I'm talking about prospective experimental studies. Evidence stronger, as I said, for AA than the other groups, but the evidence is encouraging there. Why do people change in groups? Well, some of the changes are psychological, same sorts of things you might see in psychotherapy about motivation, about efficacy, about coping, and some are social, hanging around with different people. And that's something, as a therapist, you care about your patients, but you can't really become their friend for life, but you can do that in these various fellowships. We need more research on and support for non-12-step alternatives. And just to say this again, it's great that 12-step helps so many people. Nothing works for everybody. No one should be made to feel bad. No one should be shamed if they don't like 12-step groups. It would be a terrible healthcare system that only had one thing that we offered people. We have a diverse group of people seeking care. They're going to go through different pathways. And so this is all I'm saying is this is a good one. But there are many pathways to recovery. And I think as we learn more with non-12-step alternatives, we're going to find more and more mutual help groups and help people. And also, of course, there's pathways that don't involve mutual help at all, and that's fine. The last thing I would say, and particularly I'll point to the SMART work we did in the UK, is that investments in mutual help supportive infrastructure may benefit public health and reduce healthcare costs. So those may be things that may be training professionals like we're doing right now to know about it, to encourage more referrals. Could be public service campaigns, billboards saying, look, if you have a health problem, do you know that there are groups available for all sorts of them? Sharing space with groups and community centers and churches and synagogues and mosques and everywhere else where people might donate space in hospitals. Those kinds of things can help this sort of wonderful ecosystem grow without taking it over. Because if we took it over, I think that'd be like, killing the golden goose, right? They don't want to be under professionals, but they want to be supported by professionals. And so I think that's a good place to invest some effort and time, both individually, but also at the policy level. Okay, I'm going to stop there, and we've got time for comments and questions.
Keith, thanks so much. Just really terrific. Really nice overview. You said a lot in a very brief time and covered, from the broad to the real fine-grained specific examples of kind of really highlighted for me, again, the significance of the human connection, both in terms of the clinician, the power of the clinician actually advocating, prescribing what they call social prescribing, kind of prescribing this social engagement, and then also the added value the connection, the warm handoff, so-called, with a peer from those organizations. And I think, what's really encouraging, as you pointed out towards the end, is that the potential value of expanding the repertoire of options and studies that we can do that have been done on AA that we could do for other kinds of organizations like Smart Recovery and LifeRing and Women for Sobriety, where the same kinds of things could be tested to see if we can, expand the options for people so that they can become engaged in something that would be more palatable and work for them. As you pointed out with Sarah Zemoy's work, we know that when people self-select into these, when they choose something, in other words, that's their flavor, they do well, and they do well over time. And that's just a really encouraging news, isn't it, from a public health perspective, that hopefully will lead to greater expansion of these other groups as well. So I think we can, I know there was a number of comments. I didn't catch all the comments in the chat, but I know there was a lot of flurry of maybe some of those were questions, I don't know. But feel free to unmute. Tom, we got Tom Horvath here, who looks like he's got a question. Tom.
Thank you. A plausible hypothesis about mutual help groups is that, like psychotherapy, where common factors seem to be more important than specific theoretical orientation, the plausible hypothesis would be that they all work similarly effectively. Your thoughts about that hypothesis?
Yeah, that could absolutely be true. When I finished graduate school, I was like most grad students, overworked and stressed out, and I arrived out of shape and a bit overweight to my job at the VA in Palo Alto. And the first day at lunch, all these people were out in the hallway, all my colleagues stretching and in their gym clothes. And it was because they had walking and running and basketball groups. And within 6 months, I was very healthy and had lost the weight because of that process of, okay, a bunch of people who are fun to hang around, are trying to engage in a certain set of behaviors. It's easier when they're doing it with me, and that changed me. Well, that's a lot the story of addiction, and it is not in any way specific to any particular philosophy. It's just a basic observation about our species. So I think it's entirely possible that people will benefit the same from all every one of these groups. I think that's entirely plausible. And so then the choice point becomes very important. If they all, in fact, are equally helpful, then we really want to, as clinicians, say, look, it's really up to you. I know one of these will help you, but you tell me which one. Because my job isn't to get you in any particular group, my job is to help you get healthy.
Great. Brandon, had your hand up?
Yeah. Hey, Keith. I always
Hey.
Hi. I always love hearing you talk about the mediation studies from the 90s and how they tie together. Now, I remember when I was a grad, that was like when I cut my teeth on, was the work that you all were doing in the 90s. I was like, wow, you could actually look not only at whether AA is helpful empirically, but like how. So I as a first year grad student, it like blew my mind. So it's always cool to see that. And for those who are interested, I share those PDFs. I do have a question. I remember being struck when I read your paper using instrumental variables analysis, but for the trials for individuals with drug use disorder, right, where you couldn't even do the instrumental variables analysis because the facilitations weren't as good at getting people to go right to the meetings. What suggestions do you have for researchers, and then maybe in ways like for researchers and how to work with recovery support providers, individuals like what can we all do to push the science forward to help address this issue, where obviously 12-step facilitations are really nice ways to experimentally test some of these effects. So what do we do about this issue where it's harder to get people with drug use disorder to go to meetings than it is individuals with alcohol use disorder?
Yeah, so I think there's a couple of things there. So I think one is that finding groups that are comfortable with people taking medications is important. I mean, as you know, there are people in some 12-step groups who are really negative about methadone and buprenorphine, but not all of them. And there's a big generational difference too. There was at a time SSRIs were really frowned on, and now lots of people take them, and it's no big deal in there. So it could probably be having a better knowledge of the local ecosystem, so that you don't, let's say you're a methadone clinic, and then you refer somebody, try to kick somebody to a group where they said methadone is not real recovery. So that would be hard for that person to participate. The second is, I think it's got to be more ongoing kind of support than these studies where, you know, it's remarkable in AA, I mean, pretty small interventions are getting people to go. People may need more help over time. And, you know, there are ways to do that, right? You know, companion programs, peer coach kinds of programs, but try something more intensive. Given that, you know, it's hard to completely generalize. There's obviously people with alcohol problems who have tremendous social disruption and all that, but I just say on average, the average person who say is addicted to heroin has more, you know, so their life, I just say on average, a bit more disorganized. They may need longer support to sort of make that connection and sustain it over time. And those would be really good trials to do. We've talked about that in the the NIDA CTN about maybe we need to do something that's a much more extensive facilitation connection specifically for people who have problems with illicit drugs.
Great. And just as an FYI, your sense it was borne out in the data from the National Recovery Study. John was the first author on the main paper there, where individuals whose primary substance was opioids, for example, people that identified as having resolved the problem, compared to folks with alcohol as a primary substance, those with opioids had lower levels of recovery capital, quality of life, and so on and so forth.
Mm-hmm. Yeah.
Thank you.
Thank you
for the insight, as always. Yeah.
Mark?
Hi, everybody. Brandon, thank you for keeping me honest. Keith, it was a wonderful talk. I really appreciate it, and some things I didn't know before. And the only question I have is, in the studies where they compare AA attendance or AA facilitation versus other interventions, do they account for people in the other interventions going to AA? I realize that would reduce the differences, which would be more, but I'm wondering if there's any look at that.
Yeah, so that's an interesting point. And these are conservative studies, because there are people who go to the 12-step facilitation who end up not going to AA afterwards. And then there's people in the CBT and MET who do. So as a judgment of the effect of AA, those studies are actually conservative. And that, by the way, is what instrumental variables are designed to do. So it's hard to do this without a graph, but if you have one condition, let's say it's a CBT, and 20% of people go to AA afterwards, and you have a 12-step condition and 80% of people go, you know that the difference between 20 and 80, that extra 60, is due to the fact that they were randomized to 12-step intervention, if that makes sense. And what instrumental variables modeling is doing is looking at that 60%. What explains not going, but the difference in a condition that didn't encourage it, because you're assuming that part of it is exogenously determined. And so those studies, you know, as I showed you, generally show a positive effect when you try to adjust for the fact that some people in the other condition would also go.
But it would also reduce any difference in the overall groups.
Yeah, right. That's what I mean. It's these
are
that's
the conservative part.
Yeah, conservative test. Yeah, it's like, yeah.
Does anyone look at the actual AA attendance as a variable independent of the group that people were put in?
Oh yeah, I mean, there's lots of studies like that which show, that people who go more, you have usually correlates with doing better.
Yeah.
But when you break out a randomization, then you could explain that in multiple ways. That could be a self-selection effect.
Okay, thank you very much.
Thank you.
Other questions? I got a question about online mutual help. There's a bunch of these now popping up, other mutual help organizations purely online. What do you think, Keith, in terms of relative efficacy or benefit, or how that greater access could benefit maybe more people? What do we know there?
Yeah, so, in the early days, of course, AA did this sort of stuff. They would do correspondence. People wrote in, they'd be like the only person in, Istanbul, and they would write the New York office and they would find somebody to write them back. So there is precedent to building connections without actually being in physical space. And in general, they're way more accessible for sure. There are some downsides too, though, and I say what they are. One is, like, when we studied the moderation management group, there were some, for lack of a better term, crazy kind of internet behavior in these groups, including somebody who was drinking heavily while participating in the group and posted a murder confession, which turned out to be true. And other thing, people can, cut and paste, people can flame each other in ways that are harder to do in person. So there are some risks there. The second thing is just, I've noticed, just talking to people I know who have, been to our clinic, or just people I've known socially have had drug and alcohol problems, that new people seem to find online stuff a bit less engaging. So around locally with COVID, a lot of groups of all sorts, not just addiction groups, have switched over online. And for the people who have been going for years and years, it's not that big a switch. But for new people, it doesn't pull them in the same way it does when someone can reach across the table and put their hand on your shoulder or say, hey, you want to go get a cup of coffee, stuff like that. And so we are losing. Sometimes we need high tech and sometimes we need high touch. So there are trade-offs there. But all trade-offs are relative to what the alternative is. So if there's some people would say, I would never go to a face-to-face group for some reason, or I live out in the middle of nowhere, I can't go to a face-to-face group. Well, then the comparison is online or nothing. And then I would think online is going to be better for most people.
Yeah, thanks, Keith. It's interesting, we're doing this study right now, myself and James McKillop at McMaster University in Canada, where we're following up 500 people in AA or participating in AA, looking at the mechanisms of behavior change. And it's interesting because we started, right kind of right before COVID, and then COVID happened, and then we were recruiting. And so a lot of people were engaged in the online, meetings. And it's interesting that what came out of that was, because I thought, I thought, perceived safety would be no problem on the online meetings, as it's been shown to be in the in-person. But people felt less safe, ironically, sitting at home because people would have their camera off. They didn't know who those people were in the meetings, interestingly. So I thought that was an interesting kind of anecdote that came out of that.
Yeah. And people to add to, John, people are more aggressive when they don't have a person in front of them. And there's experimental studies of that, because there's disinhibiting effects through mediated communication that you don't have when you're actually standing in front of somebody. If you say to somebody who's right in front of you, I don't like your shoes, your pants, and your shirt. And when you say, I don't like your shoes, they start to cry. You go, but I love your hat. To change your behavior. But when you're just typing merrily away, you're not getting that feedback. You might just then in this, and I don't like that about you and that, and you're really hurting somebody, and it all comes out at once. And that's one reason why it seems to me more aggressive. And also, of course, there is a lack of consequence. There are people who enjoy, if you've been on Twitter, enjoy attacking people anonymously. That's hard to do if you're actually sitting in the same room with a bunch of people who would say, hey, cut that out. So I can understand why some people would feel risk.
Well, I have to say, I always love your hats, Keith.
Oh, thank you.
Wearing one today, anyway, we sadly have come to the end of our hour today, and let's thank Keith for just a great talk. Keith, thanks for giving us your time and your expertise and experience here. It's so valuable, and it was really just, as I said at the beginning, you've really inspired a whole cadre of researchers to really investigate these recovery support services, including myself, Brandon, others who have started to scientifically investigate these resources. And also that kind of documentation of the value of these has really expanded the whole repertoire of options of, I think, other recovery support services, which are socially based beyond mutual aid, like recovery community centers. So thank you for that contribution, and thanks to you today. Thanks everybody for coming. We hope to see you next time on the Recovery Science series, and wish you all a good rest of the day. Don't forget, these are archived, so watch them, share the link They're archived on our recoveryanswers.org website. And thanks, everybody. Have a good day.
Thank you.